clinical manifestations, causes and risk factors, what will be the pathophysiology and the treatment and prevention of the urolithiasis. So you first of all you have to remember the two terminologies. One is the nephrolithiasis and other is the urolithiasis. Nephrolithiasis refers to the renal stones disease. Only the renal stone disease is called nephrolithiasis, but whereas the urolithiasis refers to the presence of the stones in the urinary tract system. Stones or calculi are formed in the urinary tract from the kidney up to the bladder. How they form? By the crystallization of the substances excreted in the urine. Incidence of the urolithiasis, as it is more common in the men, incidence of urine calculi peaks between the third and the fifth decade of the life. 80% stones under the 2 mm and more than 90% stones pass through the urinary system spontaneously. So actually there is a seasonal variation. Mostly the stones formed in the summer months because of the dehydration. And on stone formation, first of all, the crystallization is the basic theory, and the crystallization is depend upon the supersaturation of the urine with the solutes. As a result, there will be the slow flow of the urine, and there will be stasis and the saturation of the urine. There will be the matrix formation when the mucoproteins bind to the mass of the stone, and also there will be the lack of inhibitors for the crystallizations. So what are the inhibitors? These includes the citrate, pyrophosphates, glycosaminoglycans. The solubility of the stones depend upon the pH of the urine, the volume of the urine, excretion of the solutes. So stones can be anywhere in the urinary tract, either in the kidneys, ureter, bladder, urethras. So the classification of stone depends upon the various things, and the etiology, the composition, size of the stones, location, X-ray characteristics, and the risk of the recurrence. So non-infectious and infectious stones includes non-infectious calcium oxalate, calcium phosphate, and the uric acid stones, where the stones would are formed during the infectious process in the urinary tract are the magnesium ammonium phosphates or triple phosphate, carbonate, apatite, ammonium urate. And the genetic abnormalities which causes the stone formation are the cysteine, xanthine, 2,8-dihydroxyadenine, and the drug stones such as the indinavir stones. So what are the risk groups? The high risk tendency for the stone formation can be divided into following: genetic factor, general factors, disease associated with the stone formations, genetically determined stone formations, drugs which will be associated with the stone formation, and the anatomical abnormalities which will be associated with the stone formation. Risk factors, which are general factors, includes the immobility. Patients are a sedentary lifestyle with the dehydrations and metabolic disturbances, and the history of the renal calculi. Previous are the family history of the renal calculi. So there are some diseases which are associated with the increased formation of the stones. These are hyperparathyroidism. There will be more calcium reabsorption from the bones, metabolic syndromes in which there is cysteine formations, and the nephrocalcinosis of the kidneys, gastrointestinal disease, jejunal ileal bypass, intestinal resection, in which there will be the increased absorption of the oxalate, and the sarcoidosis, hyperuricuria, and the hypocitrate-uria, hyperoxaluria, and the cystinuria, primary hyperoxaluria, renal tubular acidosis, xanthinuria, and the Lesch-Nyhan syndromes and cystic fibrosis. So the anatomical abnormalities which are associated with the stone formations include the medullary sponge kidney, which is the tubular ectasia, uretropelvic junction obstruction, in which there will be the stasis of the urine, there will be supersaturation with the solutes, and sorry for the disturbance, calyceal diverticulum, calyceal cyst, and the ureteral stricture, vesicular ureterorenal reflex, horseshoe kidney, and the ureterosphere. So also they are divided according to the stone sizes, those measuring up to the 5 mm, 5 to 10 mm, and the 10 to 20 mm, and greater than 20 mm in the largest diameter. So stones locations are also very important according to the treatment plans. They are in the upper, middle, and lower calyceal system of the kidney. Either they will be in the renal pelvis, or upper, middle, or lower, distal ureter, and also in the urinary bladder. How they appear in the X-rays? These are radiopaque, radiolucents, and the pure radiopaque. The calcium oxalate dihydrate, monohydrate, and calcium phosphate, these are the purely radiopaque, and the poor radio opacity include the magnesium ammonium phosphate and carbonate apatite and the cysteines, and the radiolucent stones includes uric acids, ammonium urate, xanthine, drug stones, 2,8 dihydroxyadenine. So according to the compositions, these are the calcium phosphate stones, calcium oxalate stones, uric acid stones, cysteine stones, and the struvite or infected stones. 75% of the stones are the calcium stones, either calcium oxalate or calcium phosphate, but more than 75% are the calcium containing stones. Struvite stones are the infected stones, so composition of magnesium ammonium phosphate. 15% of the renal calculi are the struvite. These are the infectious stones, gram-negative rods, which are capable of splitting the urea into the ammonium. Then this ammonium combines with the phosphate and magnesium, which leads to the struvite stone. These are more common in females, and urine pH is typically greater than 7, means the alkaline urine. They is formed in the alkaline urine. And Staghorn stones are non-obstructive, thus painless, slow-growing, and discovered incidentally. Staghorn calculi are often relatively asymptomatic. They are branched kidney stones occupying the renal pelvis as well as one or two calcial system, and they manifest as infection or hematuria. This is the picture of the struvite stone Staghorn calculi. So uric acid stones, these are the 6% of the renal calculi. Urine pH is less than 5.5. This is the mostly occur in the acidic urine and high purine intake such as organ meats, legumes, malignancy. 25% of patients have gouts. Two percent of the renal calculi are the cysteine stones. This is the autosomal recessive trait, intrinsic metabolic defect resulting in the failure of the renal tubular reabsorption of the cysteine, ornithine, lysine, arginine, which leads to the crystallization of the cysteines in the kidney. Urine becomes supersaturated with the cysteine with resultant crystal deposition. What is the prognosis of the stone disease? 80% of the stones pass spontaneously. 20% require hospital admission or intervention because of unrelenting pain, inability to retain internal foods, proximal UTI, inability to pass the stone, renal failure. What are the recurrence rates? 40% at the 1 year, and the 35% at the 5th year, and the 52% at the 10 years, the recurrence rate of the urolithiasis. How the patient present with the urinary tract stones? They may have the pain, infection, hematuria, or they may be the asymptomatic. So obstructive ureteral stones are the passage of the stones into the ureter is associated with the classical renal colic because of the subsequent acute obstruction, proximal urinary tract dilatation, and the ureteral spasm. Acute renal colic is probably the most exceptionally painful event a person can endure. And the locations and characteristics of the pain from the ureteral stones means when the ureteral stones obstruct the urinary tract, so that depends upon the obstruction level. Uretropelvic junction, first level of the obstruction, then the pelvic brim area, and then other is a uretrovesical junction area. These are the three most common areas where the stones obstruct the ureter. These are the levels shown in the figure. This is pelvic ureteric junction obstruction, this is the pelvic brim area by the iliac arteries, and this is vesical ureteric junction. Uretropelvic junction stones obstructing the uretropelvic junction may present with the mild to severe flank pain without radiation to the groin. And the ureteral stones causes the abrupt severe colicky pain in the flank and ipsilateral lower abdomen with radiation to the testicles or the vulvar area. Intense nausea with or without vomiting usually is present. So according to the location of the ureteric stones, there will be the different presentations. For example, in the upper tract there will be the pain which radiates to flank and the lumbar areas. For the mid ureter, it causes the pain that radiates anteriorly and the caudally and can easily mimic the appendicitis on the right side or acute diverticulitis on the left side. So distal ureter and the uretrovesical junction stones cause pain that tends to radiate to the groin or testicle in the male and labia majora in the female. And the uretrovesical junction also cause the irritative widening symptoms which mimic cystitis, which is the frequency, urgency, and the dysuria. And the bladder stones usually asymptomatic and are passed relatively easily during urination. Small stones, but larger stones may lead to the obstruction of the urine, and rarely patient reports positional urinary retention. There will be the obstruction precipitated by straining and relieved by recombencing positions. So pain during the stone disease, entire process typically lasts 3 to 18 hours. Attack of the urine, there will be the acute phase and the constant phase. Peak in the most patient within the 2 hours of onset, and constant phase 1 to 4 hours, maximum up to 12 hours, relief phase 1.5 to 3 hours. So in examination of the patient, there will be the costovertebral angle tenderness, unremarkable abdominal elevation, painful testicles but normal appearing, constant body positioning movements, tachycardia, microscopic hematuria. How we will diagnose these patients with the stone disease? So first of all, ultrasound we are used in routine, but X-ray KUB, which is almost omitted for the diagnosis because only 30 to 40% of the stones can be picked up by the X-ray KUB. And it is used only the follow-up even if there is the patient with the radio opaque stones. The sensitivity and specificity of the KUB radiography is 44 to 77 and 80 to 87% respectively. It is helpful in differentiating between the radiolucent and the radio opaque stones and for comparison during follow-up. This is the X-ray KB with the radio opaque stones in the left flank area. Ultrasounds, which is the basic and primary tool for the diagnosis of the flank pain or with the stone disease. Although the pain relief or any other emergency measures should not be delayed by imaging assessments, but the ultrasound should be done in the emergency as soon as possible to diagnose the patient. Ultrasound is safe, non-radiative, easily reproducible and inexpensive. It can identify stones located in the classical system, pelvis and pelviureteric or vesico-ureteric junction, as well as the patients with upper urinary tract dilatation. Ultrasound has a sensitivity of 45% and specificity of 94% for ureteric stones, and sensitivity of 45% and specificity of 88% for the renal stones. This is a picture of ultrasounds. These are the hyperechoic shadows with the posterior caustic shadows. So IVP also omitted for the diagnosis of the renal stones. Previously it was done to see the obstructed kidney or dilatation of the pelvic calcium system. So we inject the dye, and when we take the at least 10 to 12 films up to the 24 hours. But it's now omitted because the CT KUB plane has replaced the IVP. As in this figure, there is dilatation of the pelvic calcium system. There will be the stones at here, and where is the normal left side excretion. So non-contrast CT scan. Non-contrast CT has become the standard for diagnosing acute flank pain and has replaced the intravenous urography. Non-contrast has determined the stone diameter and density. When stones are absent, the cause of the abdominal pain should be identified. In evaluating the patients with the suspected acute urolithiasis, non-contrast CT seems to be significantly more accurate than IVP. This is a CT scan which is showing the stone in the right side renal pelvis, radio opaque shadow. Non-contrast CT can detect uric acid and xanthine stones, which are radiolucent on plain films, but not the indamine stones. These indinavir stones are the only stones which cannot be picked up by the CT scan. They can appear on the ultrasound only. Non-contrast CT scan can determine stone density, inner structure of the stone, and the skin to stone distance, and all of which affect the extracorporeal shockwave lithotripsy outcome. So CT scan also help to determine about the treatment plan. Either we can go for the lithotripsy or not, or we go for the PCNL or not, or we go for the open pyelolithotomy. So for the diagnosis as well as the therapeutic plan, the CT scan is very important. In patients with the body mass index less than 30, low dose CT scan has been shown to have a sensitivity of 86% for detecting ureteric stones less than 3 mm and 100% for the calculi of greater than 3 mm. Even ultrasound cannot be able to pick up the ureteric stones, but CT scan has this ability to pick up the stones even less than 3 mm size. So after basic diagnostic tool ultrasound, we always, if we are suspecting the stone, we always go with the CT scan. So for other diagnosis, we go for the invasive technique, cystoscopy, to see the urethral stones and the bladder stones. So for the metabolic workup and for the to see the crystals, we go for the basic urinary tests, which includes the urine analysis. We see the RBCs or WBCs, nitrites, urine pH, microscopy, culture, 24-hour urine metabolites, and also for the blood structures includes creatinine, uric acid, calcium, sodium, potassium, blood cell count, and C-reactive protein. So if we go for the intervention, so the PTA, PTINR, so these are the tests which go for we'll go for to see the metabolic problems. Stone analysis should be performed in all first-time stone farmers. In clinical practice, repeat stone analysis is needed in case of recurrence under pharmacological prevention, early recurrence after interventional therapy with the complete stone clearance, late recurrence after prolonged stone-free period, and patients should be instructed to filter their urine to retrieve a concrement for the analysis. So treatment for the renal stones, first I will go for the conservative treatment, which includes the pain relief. Is the first therapeutic step in patients with acute stone episode. NSAIDs are effective in patients with acute stone colic and have a better analgesic efficacy than other opioids. Patients receiving NSAIDs are less likely to require further analgesic. Opiates, particularly pethidine, are associated with a higher rate of vomiting compared to NSAIDs, so they are less likely used. And opiate is used, it's recommended, then it is not a pethidine. So management of the stones in obstructed kidney. So there, if there will be the obstructed kidney, then we have to urgently decompress the kidney either by the percutaneous diversion of the urine or through the endoscopic. So obstructed kidney with all signs of urinary tract infection is a urological emergency. Urgent decompression is necessary to prevent further complications in the infected hydronephrosis secondary to stones induced, either unilateral or bilateral renal obstruction. Patient population which is likely to develop says includes solitary functioning kidney, bilateral ureteral obstruction, or renal failure. So decompression, currently there are two options for the urgent decompression of the kidney. Either placement of the indwelling through the cystoscopy passage of the ureteric stone, either the DJ stent or ureteric stent, or percutaneous placement of the nephrostomy tube. So after decompression of the obstructed kidney, infected urine collecting system, both urine and blood samples should be sent for culture, and they are treated according to the sensitivity. Definitive stone removal should be delayed until the infection is cleared following the complete course of the antimicrobial therapy. These are the two techniques. One is the passage of the ureteric stents or DJ stent inside, and other is the passage of nephrostomy tube outside. So conservative management for the renal stone. The size of the stone is an important predictor of the spontaneous passage. Stones less than 4 mm in diameter have 80% chance of spontaneous passage, and this falls to 20% for stones larger than 8 mm in diameter. Hospital admission is clearly necessary when following of the things are present. Oral analgesics are insufficient to manage the pain, intractable vomiting, ureteral obstructions from the stone, bilateral ureteral obstruction, and the ureteral obstruction from the stone occurs in the presence of infection, fever, sepsis, pyonephrosis. So these are the relative indications for the admission of the patients which have comorbidities like diabetic, hypertensive, renal failure, immunocompromised, pregnant. So pharmacological treatments for these stones. So calcium oxalate stones, which are 35 to 40% of the stones disease. These what will be the characteristics of these stones? So these are small, possible to get trapped in the ureter, so more frequent in men. And predisposing factors for these are idiopathic hypercalciuria, hyperoxaluria, so independent of the urine pH. It can develop in any pH, and the family history of stone disease. And the therapeutic measures includes increased hydration, reduced dietary oxalate, give thiazide diuretics, cellulose phosphates, potassium citrate, cholestyramine, and the calcium lactate, and reduced dietary sodium intake. And the calcium phosphate stones, 8 to 10% of the total stones. These are the mixed stones with the steroid or oxalate stones. The predisposing factors includes alkaline urine, primary hyperthyroidism, and treat underlying cause and other stones. And the steroid stones 10 to 15%. The 3 to 4 times comes in women, always association with the UTI. So predisposing factor is UTI, and antimicrobial agents should be used, and acetohydroxamic acids, surgical interventions to remove the stones and to acidify the urine. Uric acid stones 5 to 8% of the total stones, predominant in males, high incidence in Jewish men. Predisposing factors includes gout, acid urine, inherited conditions. And reduced urinary concentration of the uric acid, alkalize urine with the potassium citrate, and allopurinol, reduced dietary purines. Cysteine stones 1 to 2% of the total stones, and the genetic autosomal recessive defect and the defective absorption of the GI cysteine from the GI tract and the kidney excess concentrations causing the stone formation. And they are developed in the acidic urine. And how to manage these includes increase hydration, give alpha penicillamine and the thiopronine to prevent the cysteine crystallization, and potassium citrate to alkalinize the urine. So extracorporeal shockwave lithotripsy for the stones. The success of the ESWL depends on the lithotripter and the following factors, which include the size of the stone, location, the composition of the stones. Is the more harder, there will be less chances of the stone breakdown, and the patient habitus, thin, lean, or obese patients, both affected differently in the performance of the shockwave lithotripsy. Each of these factors important influence on the retreatment rate and final outcome. This is the lithotripsy machine, and the patient in the supine position, and there will be the outside corporeal shockwave lithotripsy. So there are some contraindications for the ESWL. These includes pregnancy, bleeding problems, uncontrolled UTIs, and skeletal abnormalities, arterial aneurysms, and anatomical and obstructions distal to the stone. So other techniques to remove the stones includes percutaneous nephrolithotomy. This is also endoscopic procedure percutaneously, and this is the procedure of choice and standard procedure for the larger calculi. Different type of the rigid and the flexible endoscopics are available, and the selection is based on the surgeon's preference. Prone position patients, and there will be the small opening, and through which with that dilators we reach into the kidney, and then with the endoscopy we see on the monitor, and then we do the lithotripsy intracorporeal. So there are also some contraindications to the PCN, includes patients receiving anticoagulant therapy, and others are untreated UTI, tumor in the presumptive access tract area, potential malignant kidney tumors, and also the pregnancy. So intracorporeal lithotripsy during the PCN, ultrasonic and pneumatic systems are most commonly used. So flexible endoscopies are also used, and electrohydraulic lithotripsy also used. Now recent techniques of the flexible URS, which are also used for the renal stones, but these are used for the small stones, the stone not more than 2 centimeters, but we can try with the ureteroscope, but flexible ureteroscope is best for the stones which will be lower than 2 centimeters. But if they will the complex stones, we go for the open or laparoscopic approaches. This is the flexible ureteroscope. Throw the bladder into the kidney and remove the stone. And this is the hard, rigid, which cannot approach beyond the renal pelvis. So open and the laparoscopic surgeries for the removal of the renal stones. However, if reasonable number of percutaneous approaches are not likely to be successful, or if multiple endourological approaches have been performed unsuccessfully, open or laparoscopic surgery may be a valid treatment option. And open surgeries include pyelolithotomy, stones removal from the renal pelvis after incision of the pelvic area, nephrolithotomy, incision made into the kidney substance, partial or total nephrectomy when there will the damaged kidney, and ureterolithotomy from the ureter, removal of the stones. This is the scar mark of the pyelolithotomy. So this is the treatment plan according to recommendations. If there will be the renal stone greater than 2 mm, we'll go with the percutaneous nephrolithotomy, or second options will be the RIRS or shockwave lithotripsy. And if it will be the 10 to 20 millimeter, then shockwave lithotripsy or RIRS. And if it will be the less than 1 centimeter, then shockwave lithotripsy. For the ureteral stones, treatment depends on the size of the stones. Mostly the stones less than 1 centimeter are well treated with the alpha blockers. Temsolin is one of the most commonly used alpha blocker. including other are pyrazosine, alphazosine, doxazosine, and also the NSAIDs for the as anti-inflammatory and the painkiller. And other are the endourologicals, ureterinoscopy, intracorporeal lithotripsy, or stenting. And if the for multiple times you are trying to do the URS lithotripsy but stones still cannot be able to remove or hard stones, then we'll go for the laparoscopic uterine stone removal. So for the bladder calculi, or the stones are calcified materials that are present in the bladder. They are usually associated with the urinary stasis, but can form in healthy individuals without evidence of anatomical defects, strictures, infection, or foreign bodies. Presence of the upper urinary tract calculi is not necessary a predisposition to the formation of the bladder stones. A bladder stone is usually free to move in the bladder, may cause erosions or hematuria, and it gravitates to the lower part of the bladder. There are two types of the vesical calculi, either primary or secondary. Primary developed in the sterile urine, or they are transferred from the kidney into the bladder. Secondary occurs due to the obstructive pattern, either due to the infection, outflow obstruction, and impaired bladder emptying, or foreign body presentation. They are also the mixed type, which is the most common, and they will be the calcium oxalates like the kidney or uric stones, uric acid stones, triple phosphate, cysteine. What will be the symptoms? Patient may present with the frequency, suprapubic pain, dysuria, and the pain will be worsened by the movement, intermittency, there will be the hesitancy in the passage of the urine, and the nocturia, urinary retention when it will obstruct the neck of bladder, and there will be the hematuria and interruption of the urinary stream, stone blocking the internal meatus, and there will be the UTI. And on examination, there will be the suprapubic tenderness, there will be the fullness, and occasionally it is a palpable distended bladder if the patient is unable to pass the urine, and he or she will be in acute urinary retention. How we will treat? The removal of the stone, treatment of the underlying abnormalities, management of the underlying cause of the stone formation such as bladder outlet obstruction, infections, foreign bodies is the integral to prevention of the recurrence. Only contraindication to the bladder stone removal would be the existence of the stone in the medically unstable or near terminal asymptomatic patient. Otherwise, can be removed in each and every patient. So there are multiple techniques for the removal of the stone disease: surgical fragmentations and removals. The optical lithotride are used for the stone removal endoscopically, electrohydraulic lithotride, holmium lasers, ultrasound probes, stone punch. We use mostly the stone punch to crush the small fragments and then evacuate with the Alec evacuator. And surgical approaches are used when there is a stone size is very big, more than 3 to 4 centimeter. Then we'll go for the open suprapubic cystostomy. So how will prevent the patients with the stone disease? So we have to avoid protein intake. Usually the protein is restricted to 60 gram per day to decrease the urinary excretion of the calcium and the uric acid. Sodium intake of 3 to 4 gram per day is recommended. Tablet salt and high sodium foods should be reduced because sodium competes with the calcium for reabsorption in the kidneys. Low calcium diets are not generally recommended except for the true absorptive hypercalciuria. Evidence shows that the limiting calcium, especially in the women, can lead to the osteoporosis and does not prevent renal stones. Avoid intake of oxalate containing foods, spinach, strawberries, rhubarb, tea, peanuts, wheat bran. These are things which increase the oxalate amount and which is the most common cause of this stone formation. So during the daytime, drink fluids as much as possible, every glass within 1 hour. So drink 2 glasses of water at bedtime and additional glass at each night time, awakening to prevent the urine from becoming too concentrated during the night. And you have to keep in mind there will be at least 1 to 2 liter of the urine formation per day. So you have to take as much as urine to decrease the supersaturation of the urine. Thank you very much.